Good morning, everybody. We are here. This is the first day of the EAU Congress. We are here for the UROLUTS platform. I'm Manuela Tutolo. I'm the associate editor of this educational platform. And we are here with Professor Frank van der Aa, who is one of the main experts in the field of functional urology. Hi, Frank. It's a pleasure for me to have you here. And the session on complications of slings and what to do when female slings fail just finished. Mm-hmm. And you presented interesting topics on what to do when something goes wrong with midurethral slings. And this is very interesting because we know that there is always some concern about what to do with slings and what to do when we have to redo surgery if the patient is really willing to solve the problem. So it will be nice to know, what do you think about redo surgery and what are the indications about redo surgery in the female urology field when something is not going well?
Mm-hmm. So I think, first of all, thank you for inviting me and to have this interview here. I think we had a very good discussion on the different possibilities that there are to do redo surgery. There's two main indications. I think complications, and the other one is recurrent or persistent stress urinary incontinence. So we mainly discussed on recurrent stress urinary incontinence. And I think that at the end of the session, we could conclude that we probably have to offer several solutions to our patients and discuss with them the pros and the cons of these different solutions, and then try to find the best solution for this specific patient. I think that's probably the bottom line.
And how do you counsel them? Which are the tests you perform on them, and what is the diagnostic workup with these patients?
So I think, first of all, I would call this, we push the reset button. We really do, again, a thorough history and a good clinical examination. I think we want to exclude complications of the previous surgery. And I think we really want to understand if this is really recurrent stress urinary incontinence, or are we dealing here with bladder issues, reservoir problems, overactive bladder, or even fistulae, because obviously they have a totally different solution. And once we are confident that we are dealing with stress urinary incontinence based on history and clinical examination, I think then we can proceed thinking about additional investigations and solutions.
Okay. What is the role of urodynamics tests in this field, in the field of the reassessment of the patient?
I think it's very important. I think coming back to what I've said before, I think we really want to be sure that we have a good reservoir function, that the bladder functions normally, because in a large subset of patients there will also be bladder issues. There will be urgency incontinence, overactive bladder, or even compliance disorders. So we want to rule out these problems, or if they are present, we want to take them into account, offering a new solution, or using multimodal treatment. Yeah.
Exactly. And we have seen during the session that you and the other speakers defended different options for the reduced surgery. So can you just explain what would be the different options and why fasciolata or autologous sling can be a good option in the reduced surgery?
So I indeed defended fasciolata sling, but to be honest, in my real life practice, I also offer different solutions. So for me, the specific or the positive aspects for autologous solutions are these patients that still have some urethral mobility. It should not be a fixed urethra or intrinsic sphincter deficiency, because then every sling surgery will be very obstructive and will have new problems like voiding dysfunction or OAB on the long run. I think the patients who have some postmenopausal atrophy, patients who had previous sling complications, for sure, they are the real index patients where we want to go for autologous sling.
Okay. And what are the complications of fasciolata when you propose this to your patients?
Well, I think we can even say that there is rather than really complications, there are side effects of these slings.
Yep.
And these slings can be obstructive, so they can give voiding dysfunction and they can give de novo urgency. I think if you're experienced and if you do a thorough clinical examination, you can ascertain the level of urethral mobility. And this is not a black or white phenomenon, it's a continuum. And the less urethral mobility you have, the more probable you will put your patient into voiding dysfunction, into reservoir issues, overactive bladder problems. And so I think this is a point of discussion and talk with your patient.
Exactly, because I think that at the end, we can conclude this discussion telling that no size fits all. So you need to really counsel your patients because you want to fix something, but on the other hand, the problem can be avoiding dysfunction afterwards. So what do you think about the counseling in this specific field?
Well, I fully agree. I think one of the first speakers today started the talk with saying that every second surgery is more difficult than the first one.
Exactly.
And this is true. So if you read success rates in literature, which is not rocket science because there is very little high-level evidence, but success rates go up to 60 to 70%. If you look at continence rates, 50, 60, 70%. If you look at improvement rates or satisfaction rates, we can reach up to 80%.
Exactly.
But so we must be humble, and we know that 20, depending on your success definition, but 20% up to 30 to 40%, we'll have to accept a level of discomfort, and we cannot get all our patients perfect, unfortunately.
Yeah. And the last question, what do you think about a redo synthetic sling? Because I wouldn't be so convinced because of the quantity of prosthetic material you put in the body. So what do you think about a redo surgery, for example, with a different route of insertion?
So I think, first of all, it depends a little bit on where you are in the world because the legal system might be different in different settings. I personally do sometimes offer redo synthetic sling, but it requires good tissue quality. It requires a good urethral mobility. Sometimes a previous mesh is not adequately positioned or it really has loosed. And so there are some indications, but I think we should be cautious. And as you rightfully mentioned, putting in extra mesh will increase the risk of mesh-related issues. So we have to be cautious and we have to really consider the different possibilities. But in my opinion, in certain patients, redo synthetic sling can be an option still.
Okay.
Yeah.
We thank you very much, Professor Vanderá. Thank you very much for this opportunity. And to conclude, no size fits all, so we should counsel our patients and select the best patient for the best procedure in that specific case. Thank you very much.